Good evening and Happy New Year to you. It's Ask the Specialist once again on CMU Public Television tonight. We ask the doctors. I hope you'll join us with your questions. Good evening, everybody, again, and thank you for joining us. We want to take your questions tonight with the doctors joining us. So you can phone us in at 800-727-9268. Find us on Twitter at WCMU_AskThe and via Facebook, facebook.com/AskTheSpecialist. I want to welcome our guests, Dr. Omar Haqqani, Chief of Vascular Surgery at Mid-Michigan Health. Sir, welcome to the program tonight.
Well, thanks for having me.
We're happy to have you. And Chief of Vascular Surgery, what kind of questions can we sort of direct towards you tonight? What's your specialty? How does that work for us?
Right, so vascular surgery entails surgery of the vascular system, namely blood vessels, arteries, veins, and lymphatic system. And typically, as a large cohort of patients as we get older have a large number of disease pathologies that are focused on the arterial and venous system, and a vascular surgeon is one that focuses on managing those diseases both surgically and medically.
Very good, sir. We're happy to have you with us. Thank you very much. We're also joined by Dr. Judy Indrakumaran. Thank you very much for joining us. Family medicine physician with the Mid-Michigan Health as well.
Thank you.
Welcome
Thank you for
to the
having
show.
me.
Yeah. As a family practitioner, what are you experiencing right now in the office? What's sort of on the uptick right now? Are we people dealing with flus or colds or?
Yep, we do see a lot of flus, colds, upper respiratory infections for sure. But family practice entails pediatrics to geriatrics. So we do see a wide variety of daily chronic medical conditions.
All right, very good. We thank you very much. Get those phone calls coming in through, folks, and we'll try to answer as many of your questions as we can. We've got a couple left over from last time, and Dr. Haqqani, we'll start with you. The question is, what is the process like for removing varicose veins?
Oh, that's a great question. So varicose veins is, in essence, a common etiology that a lot of people seem to know the words but may not understand what the disease pathology is.
Sure.
In fact, so varicose veins can vary from just a cosmetic deformity that people have some dilated veins, usually in the legs, in the calf, and in the lower extremity, to more advanced disease pathologies where, in fact, they start to develop discoloration or wounds that are non-healing. And in fact, so arteries are blood vessels that take blood away from the heart, and veins are those blood vessels that bring blood back from the heart from the lower extremity. The veins have valves in them, and the purpose of these valves is to make sure that blood flows only in one direction. When the valves are dysfunctional for a number of different reasons, the blood essentially is not able to get back to the heart, begins to pool in the legs, and causes a whole series of cascade of reactions with edema or swelling, discoloration, and of course that can, in more advanced stages, as I said, can lead to non-healing wounds. Now, from the cosmetic standpoint, dealing with varicose veins, the olden way of removing them was called vein stripping. It was an incision in the groin and an incision behind the knee, and was essentially a physical removal of the vein. And now we're able to remove veins in more advanced ways with something called radiofrequency ablation or laser therapy.
All right, very good. Appreciate that. Dr. Indrakumaran, we have a question from a caller in Posen. They had carpal tunnel surgery about 9 weeks ago, and they're still having tingling in 3 fingers. Is this typical?
To be very honest, that's more of the orthopedic specialty, but tingling only in the last 3 fingers? Or the first 3?
They weren't specified, just 3 fingers.
So it depends on exactly if it's the last 3 or the first 2 digits. It varies with the median nerve and the ulnar nerve, so you want to be specific about which digits exactly. I would say for sure to follow up with the surgeon to make sure that there's no other issues going on with that.
Very good. Another question for you too, out of Gaylord. Can bone spurs in any joint Can you get bone spurs, in any joint, and what causes them? What is a bone spur?
You could get bone spurs basically in any joint, but most commonly it's seen in the foot So usually where you have a lot of wear and tear, basically, so it's a lot of pressure points, usually in the pressure points, so it's usually in the metatarsal, which is closer to the toe area, that you would see them commonly in. And they, well, usually we say to use inserts, so commonly seen in the feet, usually from a lot of pressure points.
And how might you go about fixing that problem?
Yeah, so it depends on how severe the bone spur is. Depending on the severity, you can use inserts to comfort the spur so you don't get as much pressure point on that. And also seeing the podiatrist or the orthopedic who specializes in the foot can basically go in there and shave it down. It's a surgery that you can do to fix that.
All right, thank you. Dr. Haqqani, a caller from Helston, they ask, what do you do for leaking veins in legs? Is that essentially what we were talking about before?
Yes, that's very similar. So when the mainstay of management for varicose veins is compression stockings. And that's something that can be obtained through a prescription with your primary care doctor or by seeing a vascular surgeon to determine whether in fact that will be of any benefit for you. If those compression stockings do not help over a period of time, as I said, there are interventions which can be taken, which can be radiofrequency ablation or laser therapy. And in essence, the radiofrequency ablation is a day procedure. It takes about 20 minutes to do and involves a small puncture to cannulate the vein in the thigh. And essentially using heat, we're able to ablate the vein. And that helps a lot of patients out. And in fact, many of the times I do at the same time something called stab phlebectomy, which is to remove the varicose veins that are in the lower thigh. And again, it's a day procedure. The recovery time is generally a couple of days, and patients are able to get back to their regular work thereafter. Many patients benefit tremendously for this procedure, and in many cases it is covered by insurance and Medicare.
All right, thank you. Dr. Indra Kumar, and we've got a question in through Twitter. Again, you can follow us on Twitter at WCMU_AskThe. And this tweet asks, is there a difference between emphysema and COPD? Is the treatment for emphysema the same as the treatment for COPD? So how do they differ? And then how about the treatments then?
Okay, so COPD, which is the chronic obstructive pulmonary disease, can be either asthma or emphysema, or emphysema and COPD. COPD actually is a generalization term, and then under that umbrella kind of falls emphysema and asthma. So they're both chronic obstructive pulmonary disease. With emphysema, usually you get that from smoking. It's actually either result of long-term smoking or an enzyme, which is elastase. So it's also an alpha antitrypsin deficiency that can cause it as well. So two different reasons that emphysema can be caused, but most common reason here in North America is mainly smoking. So I'm not sure if that answers the question, but yes, so emphysema actually falls under COPD, and it is sometimes interchangeably used. And the treatment for that, it varies on the severity depending on if it's mild, moderate, and you go through steroid inhaler treatments, rescue treatments, which is albuterol. You can use inhalers, as well as they use prednisone, which is a pill form of steroid, to also help with that, and then yeah, so.
All right.
And eventually oxygen if it's that severe.
Okay, very good. Dr. Haqqani, a question out of Midland. They had anemia as a child. Now they're 80 years old, or will be 80 very soon. How much iron should I be taking?
That's probably a question to my colleague here.
Okay.
But iron, essentially anemia, can be due to a number of causes, and this is more of a medical side of things, but patients who are at 80 years of age who have anemia should have a thorough investigation to determine whether or not, what is the actual cause of their anemia. Anemia can be a sign of a number of diseases, from occult cancers all the way to malnutrition and other disease states. So a good family doctor and practitioner would be able to do the necessary tests to be able to determine the type of anemia, and then determine whether or not iron is really the true treatment for this versus a more underlying etiology.
Okay, very good. I see carotid artery in the question, so I think we're safe here. Concerning the carotid arteries, a person is 62 years old and has had an ultrasound and was told that it was a 50 to 60% block. Is this normal? Should they be concerned? And they're supposed to have an ultrasound every year. They've had 4 vessel bypasses in the past, is the note here.
Now that's a great question. So carotid disease is a disease state that is common in our population, and it affects those patients that are smokers, high cholesterol, diabetes, or predominantly those patients who have sedentary lifestyles. The carotid artery is the main artery that goes to the brain. And the issue with carotid disease is that the carotid arteries are notorious for accumulation of plaque and debris. The issue is that when plaque becomes dislodged and essentially goes to the brain, that's what causes a stroke. And stroke is, as we know, one of the #1 killers in our society today. Now, in 80% of the patients, the etiology for stroke can be due to cerebrovascular disease, namely the carotid disease. So that kind of taking the pretext of things, when you look at carotid disease, you can break patients down into 2 categories. Those patients who've had symptoms and those patients who have not had symptoms. Well, what are symptoms? Symptoms can be loss of vision in an eye temporarily, or paralysis in an arm or a leg, garbled speech that comes and goes. That's what's called a transient ischemic attack. With more advanced forms, patients would develop a full stroke or a full paralysis or full neurological deficit. Those are symptoms of a stroke that in many cases can be due to carotid disease. So when you break those patients down into those that have had symptoms and those that haven't, those patients who've had symptoms, the data shows very clearly when you look at the carotid trials that those patients with 50% stenosis or more benefit from surgery, okay? Those patients who have not had any symptoms, the studies show that there is a benefit, statistical benefit from intervention when they're 60% or more narrowed. In clinical practice, however, most vascular surgeons won't intervene until they're 70% or more because the risk of developing a stroke in an asymptomatic patient with that degree of stenosis is quite low. The natural history may be 1 to 2% per year. So it's important to understand that you limit your lifestyle factors, so you're on a statin or a cholesterol medication, an aspirin and or Plavix, and you stop smoking and keep active lifestyle. Yes, for having yearly ultrasounds, and of course the whole issue of carotid disease and carotid management is very complicated, but it's best to deal with a vascular surgeon who's able to manage your carotid disease effectively.
All right, thank you, Dr. Haqqani. For Dr. Indrakumaran, we have a question out of Saginaw. They note that they have nasal passage problems and always use nasal spray. Is there anything else you can do to fix this problem? And I'll just sort of add, I've heard myself nasal sprays sometimes can even result in problems down the line. Is that correct? What is their issue here?
So with the nasal passage obstruction, I'm not sure if this is more of an allergic rhinitis or if there is a polyp in there, but depending on what the issue is. So with what we call allergic rhinitis, which is usually from, you'll have symptoms of congestion, stuffiness, and people use nasal sprays. Now nasal spray, I'm not sure if they're talking about just the over-the-counter nasal spray or if it's a steroid nasal spray.
It's not specified here.
Okay, so depending on, for example, if it is allergic rhinitis, you want to get into a good regimen. First of all, you want to see your primary care doctor. If it's severe where you've had chronic allergic rhinitis with infection, you want to also maybe even see an ENT specialist depending on how severe it is.
An ENT specialist?
Yes, so it's a ear, nose, and throat specialist, and they're very specific about if you've had chronic issues with recurrent infections, with sinus infections, and you keep getting it, then you might sometimes require surgery. Sometimes you can have fungal infections up in your nose. So it depends on, for example, so the nasal spray. If it's allergic rhinitis, if you have congestion and you're trying to relieve that, you want to first of all use nasal saline sprays. They're basically salt water with a little bit of bicarb in it. Really does help relieve the congestion. If you use it daily, it actually helps prevent dryness as well and nosebleeds, which is a lot of people with allergic rhinitis get. Another thing is if you do have chronic issues, getting our nasal steroid spray, which is very minimal doses of nasal steroid, and it actually helps prevent the inflammation which causes the congestion and the constant drainage. And then also getting on a really small dose of antihistamine. Depending on if it's during the day or at night, you want something non-sedating during the day. So there's a couple of issues that you want to address. And over-the-counter nasal sprays, a lot of them cause rebound drainage actually and congestion. So if you use it on a long term, it's actually making it worse. Okay. So you want to be careful what exactly you're using. Take that spray into your doctor and kind of show that to them and address the actual issue and get to the bottom of that.
All right, very good, thank you. A question from Cadillac, again back to varicose veins. They note that they served in Vietnam, and they're curious, by chance, if their varicose veins are related at all to the exposure to Agent Orange.
That has been I have heard that actually among some of my patients. I have not come across any literature that has documented that Agent Orange is any relation to varicose veins. Agent Orange, in fact, has had some link with arterial disease and rather than venous disease, so the arteries rather than the veins. But I have not come across any data that Agent Orange is associated with venous disease.
Okay, interesting to even know that there was a tie. Something I wasn't familiar with. A caller out of Midland, I believe, to Dr. Indra Kumaran. They have Suto Gout. And none of the doctors that this person has gone to have given him a good medicine for it. What might you recommend? And what's Suto Gout versus just what we've heard of commonly as gout? Is it the same thing, or?
Right, so there's gout and Suto Gout. Gout is more known for uric acid that causes it, whereas these are different crystals in Suto Gout. And it's actually microscopically differentiated by the shapes of the crystals that they find. Usually, that with Suto Gout, normally, even with gout itself, we usually get the rheumatologist involved. It's actually a subspecialty that manages that when it comes to gout or Suto Gout. If it's on a chronic basis, we do manage medications, but initially when we diagnose them, we send them to the rheumatologist. I'm not sure if this patient has been seen by a rheumatologist, and they do have several medications that kind of inhibit the formation of the crystals that do work, but I wouldn't specifically recommend a specific medication, but I would say seeing the rheumatologist, who's their specialty, would be my recommendation.
All right, very good.
Yeah.
So there is some hope out there potentially,
for
depending
sure.
on...
Yes, there are treatments for it, and usually the medication that you have to try different variations depending on how severe the gout is in general, but there are different types of medication that work in different enzymes. I would say, first of all, inhibiting the formation of the actual crystals, secreting the crystals, and so therefore it depends. I'm not sure which medications they've actually tried, but I would say if they haven't seen a specialist, maybe seeing a specialist would be the next step.
All right, very good, thank you. Out of East Tawas, the caller notes that they're 70 years of age and have a high triglyceride count in the 400s. They're experiencing some lightheadedness, and it has been happening for a few months. They're curious why.
Okay, so lightheadedness can be due to, again, a number of different factors, but with triglycerides in the 400, the current recommendation and guidelines are for strict triglyceride control. Those patients, especially in their 70s, who've had uncontrolled hypertriglyceridemia, are best served with medications to be able to limit them. It's very likely that such a patient has some element of either carotid disease or coronary disease, and it's important to understand and evaluate the etiology through either a carotid duplex ultrasound and as well as some further imaging studies to determine exactly why they're having these lightheaded episodes. A cardiac evaluation to determine whether or not there's any signs of arrhythmias or atrial fibrillation is also warranted in this case, and she should see her doctor.
All right, very good. Dr. Indra Kumaran, a question from Alpina. This person has arthritis in their thumb. What can they do about it?
All right, so arthritis, it's a general term. There's osteoarthritis, there's rheumatoid arthritis. If it's usually one joint, it's usually osteoarthritis, but generally we recommend still obviously having that examined by a physician. But it's very, actually, especially a female patient, it's very common for females to develop first signs of arthritis in the base of the thumb. It's usually the first finger, which is the base of the thumb, that's a common initial sign of osteoarthritis. So I would say, initially what our treatment for osteoarthritis is, most of the patients with osteoarthritis actually don't use their joint. We tell them to exercise. Physical therapy is a great way to sort of learn the right exercises to do to prevent osteoarthritis from getting worse. Another thing is NSAIDs, what we call non-steroid anti-inflammatory drugs. Aspirin does fall under that, ibuprofen, naproxen. Obviously, it depends on the age of the patient. The older patients, we worry about ulcers in the stomach that forms as a result of these medications. So we always tell patients to first see a physician, see what your other chronic medical conditions are, what other medications you're taking. Do you have kidney functions that could possibly, maybe you have to be careful with the medications that you're taking. These medications used on long-term pain medications, just as even ibuprofen, Advil, any of these medications can actually cause kidney failure. So you have to be careful of the adverse effects. So don't overtake medications over time just for pain. Go in and actually see your doctor to figure out if you have a different type of osteoarthritis. There are other symptoms that we should be looking for. So sometimes we kind of overly diagnose osteoarthritis. There are other forms of arthritis and autoimmune diseases that can cause issues as well.
All right, very good. I think that was some helpful information to just, if you're chronically taking some medication, taking care of yourself,
Right.
follow through and see why you need to do that. Okay,
Exactly.
very good. Dr. Haqqani, a question from Petoskey. They ask, can you explain what a dissected aorta is?
Sure. So the aorta is a large freeway or highway of the body that carries blood from the heart. And it essentially comes from the heart. And as the aorta travels through the chest into the belly, it has a number of branches that provide blood flow to the kidneys, to the intestines, and the lower extremity. And the artery itself, this freeway, has multiple layers in them. In fact, it has a layer called the intima, and a layer called the media, and a layer called the adventitia. When there's a small tear within the artery itself, blood begins to travel. Instead of the main freeway pathway, it creates its own pathway between the layers. And this can either result in a number of issues. Either A, the dissection can travel through the layers and come out the other side and cause an acute bleed, in most patients who would die in that particular instance, or the dissection can limit itself and start going into the branches and start affecting the blood flow to certain organs, which would be a surgical emergency. Or thirdly, the dissection can be limiting and become an endpoint, at which point blood pressure control would be an issue. So a dissection really has to be divided into determining whether or not the patient is symptomatic or if the patient is not symptomatic, and that is dependent upon their symptoms and the imaging and the flow to the organ that's involved. Most dissections are managed with strict blood pressure control. And that's one of the issues, is that patients who have uncontrolled hypertension develop a small tear within the inner lining of the artery that begins this whole traversing of blood through those layers that can cause a serious problem. So again, blood pressure control, follow-up for aortic dissections is important, because those patients who do have an aortic dissection are more prone to develop an aortic aneurysm, at which point that would need to be treated at some point if it's clinically significant or meets the size criteria.
All right, thank you. Caller from Lapeer for Dr. Indra Kumaran. This caller notes that when he sits up in bed in the morning, he has a problem with sinus drainage. What can you do about that?
Okay. With sinus drainage, I think just like before, that's also another underlying issue of allergic rhinitis, we usually say. Now, I'm not sure if this is a chronic issue, which is an everyday thing, or if it's just a couple of days. Depends on how long they've been having this drainage. Usually in the morning, it's very common to have allergy symptoms, and I'm wondering if this is related to some sort of allergies, seasonal allergies, change in weather. Once again, I usually recommend nasal saline washes. They're very benign. Usually they have salt water with a little bit of bicarb. Using that usually helps with the drainage. So it depends, going in, maybe seeing if there is some underlying allergies that need to be treated with antihistamines. So I would recommend getting that investigated, but normally normal saline washes might help with that.
All right, thank you. For Dr. Haqqani out of Alma, and I might need a little help with this question here. They ask, what is the difference, or which would you recommend for AAA repair? Open surgery or endovascular? First off, what is AAA repair? And then if you could explain the options there between the two.
Okay, so that's a good question. So AAA means abdominal aortic aneurysms. Now, again, back to the aorta we were talking about, which was the main freeway that comes from the heart and provides most of the blood flow to the body. The aorta, typically in the belly component, is about 2 centimeters. When the aorta begins to dilate or begins to expand abnormally, there's an increased tension in the wall of the blood vessel, and the concern is that as the aneurysm, is what this is called, becomes large enough, it may rupture. Now, those patients who have an abdominal aortic aneurysm that rupture, 50% of those patients die instantaneously. Out of those patients that make it to the hospital, typically 50% of those patients die. So there's a 75% mortality rate associated with abdominal aortic aneurysms that rupture. Now, the issue is, when you look at the studies and determine, well, when should you treat patients with abdominal aortic aneurysms, the data from the small aneurysm UK trials demonstrate that usually you want to treat at 5.5 centimeters. Now, there are patients who are at a higher risk of rupture, such as those that are female or those that have something called COPD, or a chronic obstructive pulmonary disease or those that have intractable hypertension, they're at a higher risk of rupture, so you may want to treat them earlier at the 5 centimeter mark. So that is abdominal aortic aneurysms. So we want to treat them once they're at 5 centimeters or more. There's 2 ways to treat abdominal aortic aneurysms. The traditional way is an open repair. It's an incision in the belly, and essentially it is to clamp the abdominal aorta and to put in a prosthetic Dacron polyester new aorta in order for the patient to be able to circumvent the risks of rupture. Now, in the last 10 years, technology has changed and allowed us to be able to repair abdominal aortic aneurysms in a minimally invasive way through small incisions within the groin to allow deployment of stents that allow us to cover the aneurysm such that the blood flow goes through the actual stent complex and does not pressurize the aneurysm. When you look at the data between open aneurysm repair and this new endovascular aneurysm repair, the 30-day complication rate from an open repair is about 6 to 7%, and that includes infection, heart problems, stroke, or death. When you look at the endovascular, the minimally invasive way, it's only 1.8%, so far less. Most of my patients who have the endovascular repair leave the hospital the very next day. When you look at the open repair, most patients stay for about 5 days to a week in the hospital. However, when you look at those patients long term, 2 years, 3 years, 4 years, there's no difference in outcome in the way that they were treated. So the bottom line is, for my patients, if they meet the criteria, and there's a lot of complicated anatomical criteria that are required to determine whether or not a patient would be amenable to an endovascular repair, but if they do meet the criteria, then they're better served by the endovascular approach. However, if they, for whatever reason, have a larger aneurysm that is not amenable to the endovascular repair, then I do those patients in the traditional open procedure. And that is why you want to see a vascular surgeon.
Very good. We'll have to leave it there. The half hour flies by. Folks, I want to thank you for joining us. Dr. Omar Haqqani, Chief of Vascular Surgery at Mid-Michigan Health, and Dr. Judy Indrakumaran, a family medicine practitioner with Mid-Michigan Health. I'm Rick Westover. Thanks for joining us, and we appreciate answering your questions today. Thanks a lot.